Thank you very much for the invitation. Thank you, Carlos, for having me here in the University of San Francisco, Dr. Maldonado. Listening to my two colleagues before, I realized two things. One is that all the speakers today do not have a tie. I'm the only one, so I will remove this tie for a second reason, though. And the reason is that it's piezing my neck. So it's piezing my neck and probably decreasing the blood flow to my brain, and probably I won't have a very good presentation. So sorry, Dr. Davalos, for taking the tie off. So my speech would be less experimental. The objective would be to give you an idea about the history of brain death, how people were dying before, and how people are dying now, and also what happens after somebody's diagnosed brain death, and what happens afterwards, and how you can, through death, bring in life to other people who need that. So I'm going to use this, I guess. So since the dawn of man, all humans have followed a similar path, okay? Either you were Alexander the Great, or you were Gaius Julius Caesar, or you were Queen Elizabeth I of England, probably not the most nice person for Spanish-speaking colleagues here. This guy that you know very, very well, okay, Simón Bolívar. Also figures of the 20th century, a giant of the 20th century, but also the common man and woman. All these people have a common, similar path. And this similar path is that they were born one day and they died another day. And obviously you know immediately what's the first on the top, what it shows, the pyramids. The second one is from my country, it's the Atreus tomb in Mycenae. And the last one is in Normandy, the cemetery in Normandy, France, where soldiers of the Second World War were entombed. So how did they die, all these people, over the centuries, the millennia that had to follow the man? They have died because their heart stops, and then by stopping, the heart stops, and then there is no blood circulating, and then the breathing stops, and then all the organs stop functioning, and eventually you develop rigor mortis. Or your breathing stops for some reason, you have an injury to your high spinal cord, and then you cannot breathe, and then the heart follows, and all the organs develop irreversible injury, and then the rigor mortis follows. So this has been the history of man and the history of dying since 1959 in all human history. So why 1959? Why 1959 is an important year? Well, because I was born in 1959. No, it's not that. It is that the decade before 1959, in the 1950s, the iron lung was developed, and this was because of the polio epidemic. And for the first time, we were able to ventilate patients who could not breathe. So in 1959, there was an obscure, actually, paper initially in France, in the Revue Neurologique, by two professors, and Pierre Mollaret and Maurice Goulon, and the title of the paper was Le Coma dépassé. So Dr. Rao just spoke about coma. We are talking about the beyond coma situation. So these two French professors realized that, there is a new way of people dying, or what is happening with the ventilators. So these are the two professors. In essence, what was new in 1959 for them was that you have a catastrophic brain injury, and then the brain stops functioning, okay? Including the medulla oblongata, so you cannot take a breath, and also the cardiorespiratory center collapses, and then you cannot take a breath, and then obviously the heart becomes insensitive. The heart does not stop immediately, so you still have a heartbeat in these patients because the ventilator is breathing for these patients. And then if you continue supporting them on the ventilator, still Later on, down the road, after a few days, in essence, the heart also stops and the whole system collapses. And this has been corroborated by the NINDS brain death study that was published in 1979. It took 10 years to cross the Atlantic, and in 1968, there was a committee, it was called the Ad hoc Harvard Committee, led by an anesthesiologist, by the way, that published this paper in JAMA, as you can see in 1968, and the title was A Definition of Irreversible Coma. And I'll show you the criteria that they figure out. So this was the JAMA cover, and it's interesting, actually, that it had another paper about the plague, the Black Death, and as you can see in this painting, it is represented by a rat tail of this bat, actually. So they have realized that something was, this painting is from 1898, and they have realized that something was wrong with the mice at that time. So these were the criteria from the Harvard Ad hoc Committee, and as you can see, they said that this patient is brain dead if you have unreceptivity and unresponsivity. There are no movements or breathing. There are no other reflexes, brainstem reflexes, and there is a flat EEG. At that time, the technology they were using was AEG. They didn't have even a CAT scan in 1968. And all the above had to be repeated, and then you have to exclude, that's very, very important, you have to exclude situations that can make you look brain dead. Hypothermia, if you drop into an Albany lake or Michigan lake in the middle of the winter, believe me, you look brain dead when you arrive to the hospital, but you are not necessarily. And of course, CNS depressants, paralytics, and stuff like that. So that was very, very important. And then another decade has passed. In 1981, the President's Commission of Bioethical Problems published this criteria on how people in the United States die. So you die by two ways. One is if you have an irreversible cessation of circulatory and respiratory functions, or if you have an irreversible cessation of all functions of the entire brain, including the brainstem. And how do you diagnose that? You diagnose it according to accepted medical standards, which is kind of nebulous, but still help people advance the science of that. And same year, actually, in 1980, 81 was published and was approved by everybody. It became the law of the land. So it became the federal law in the United States how people die. And as you can see, the verbatim, they used the President's Commission, and I put it here just to see exactly the same words: irreversible cessation of all function of the entire brain, including the brainstem. So slowly, one state after the other espoused this law, and right now all 50 states in the United States have something in their laws based on this. As we speak, there is a commission by judges. I'm involved in this commission as an observer to update the UDDA. So very soon we may have changes on this. We'll see how things will evolve. In 1995, the American Academy of Neurology published the first brain death guidelines, and it had also specific temperatures. As you can see here, the core temperature should be above 32 degrees, for example, and other criteria. And in 15 years later, in 2010, we published with some other colleagues, Elko Wijdziks from Mayo Clinic and David Greer from at that time he was at Mass General, and Gary Gosrath, he's the chair of the department in Kansas. And we published these guidelines that are still the guidelines that the American Academy of Neurology is using, and everybody in the US is using. Very, very soon, this year, in a few months actually, you'll see the new guidelines, because we revised the guidelines from 2010. So just wait and you will see. And there are changes there. You'll see the changes. So this is a very busy slide, and I'm showing you this just to give you an idea that religious objections have always been about this. I mean, you have somebody who is ventilated, but the heart is beating. Is this patient dead or not? So the Catholic Church, actually, in John Paul II, actually supported this. The Eastern Orthodox Church, including the Church of Greece, supported this. Most of the Islamic organizations supported brain death, but there are still some people who don't espouse the brain death concept. Reform and conservative Jews also supported this, but there are still some ultra-Orthodox Jews that do not believe that these patients are dead and the heartbeat is the key. And then, I don't know if you can see it very, very well on the bottom, you have 4 states in the United States, California, New York, Illinois, and New Jersey, that have specific, in their laws, specific guidelines about accommodation period. So if the family has an objection to brain death, then you cannot necessarily remove them from the ventilator or proceed to organ donation. New Jersey is the only one on the very bottom that if you have, for religious reasons, you object to brain death, you cannot even do a brain death exam. So that's the only state in the United States. In 2020, we published this very important paper in JAMA, the World Brain Death Project, and we look at what is happening around the world. And there is variability, tremendous variability. Each country has different criteria, but all of them, bottom line, all of them use the same criteria that can be traced back to the ad hoc committee, the Harvard ad hoc committee. And this is a map, actually, of countries in the world that have brain death policies or not. It's interesting here, actually, you can see that Bolivia doesn't have, I don't know that, I don't know if Manuel is here in the audience and he knows about this. And then Guyana, I guess, is the other one in Latin America that doesn't have. Many countries in Africa, of course, do not have. In Europe, interestingly, Belgium, for some reason, did not have. So this is a map of countries that have brain death. So as you can see, the vast majority of the world has espoused brain death. Okay? So how does a patient become dead by neurological criteria? And what do we do? First and foremost, and very, very important for you to realize, is that as physicians, we have, because of our Hippocratic oath, we have to treat the patients, even futile cases, to maximum. And this is what we are doing. We need to treat them maximum to try to keep them alive. I can tell you, and Chetan and Nelson can tell you also, that you know from the beginning that you cannot save a patient's life, but still you're going to try to save the patient's life. You're going to do everything you can in medicine of 2023. But sometimes you win and sometimes you fail, unfortunately. So if the patient reaches the point that is in very deep coma with a Glasgow coma scale of less or equal to 5, then you call the OPO, the Organ Procurement Organization. It's mandatory in most states, in fact. And then you examine the patient, and if the patient meets all the prerequisites, and the prerequisites are, he's not paralyzed, he's not sedated, he has a good temperature, he has a good blood pressure, the labs that you have are not extreme, then you proceed to examine the patient, and you have the clinical evaluation. It has a few components. You need to have cerebral unresponsiveness and deep irreversible coma. Okay, and I'll show you what means irreversible coma in situations like that. You need to have absence of all brainstem reflexes. You examine the patient from all the reflexes that you can examine in the pupils, ears, you inject cold water in the ears. And then in the end, after you finish that, you proceed and you do the apnea test. You disconnect the patient from the ventilator and you try for a few minutes to see if the patient takes any breaths. It's much more complex than that, but sometimes it takes 20 minutes to confirm that. And then you can do also confirmatory tests, and I put plus minus because sometimes you need them, sometimes you don't. You just go with a clinical exam, and then of course you need to document that. And this is very important to document the time that you conclude that the patient is brain dead for legal reasons. Because this patient who is declared brain dead is legally dead. Okay? So this is a normal CAT scan, as you can see. So you have the brain, and you have on the right sulci and gyri, you have the CSF around the brain, and you have the ventricles in the middle, and then you have the basal systems and the lower part, and then you start seeing the thalami and probably the upper part of the brainstem there. And you have all the situations that we deal with in the neuro ICU, as everybody, all my colleagues can tell you. So you can have a large ischemic stroke on the very left. You can have a huge bleed in the parenchyma of the brain with extension into the ventricles. On the second one, you can have a large subdural hematoma that is compressing the brain post-trauma, compressing the brain from the right to the left. You can have a bullet that is passing from the right, is piercing, and then there is blood obviously in the path, and then it exits from the other side of the brain. And then you can have loss of everything that you have there, sulci and gyri. We have massive edema post-cardiac arrest. You have somebody who had cardiac arrest, and we're doing CPR for a certain period of time, and then you get a CAT scan, and this is how the brain looks like. So this is how these patients become brain dead. Bottom line, in all of them, eventually, the blood stops getting into the brain. It stops here at the base of the skull in the petrosal part of the brain. So there is no blood going to the brain cannot survive. So when these patients are declared brain dead, then they are legally dead in the United States. So what happens after that? The patient is still on the ventilator, which is breathing for the patient. The heart is beating, blood is circulating, but almost all of these patients are supported with medications to bring the blood pressure up because the blood pressure crashes and the heart rate doesn't change at all. The brain controls everything in the body, including the heart. And the organs, most of the time, are perfused and functioning well. So what do you do? Then the next steps would be, we meet with the family in a quiet environment, in a room, not in the corridor, in a busy hospital, or outside the room of the patient, or even inside the room of the patient, in a separate room. And we talk to the family, and we tell them what exactly happened. And then when we declare the patient dead, brain dead, we explain to them that the patient is legally dead, and then we answer all the questions that they have. And at this point, after we finish talking to the family of the patient, then this patient meets the criteria of death, the dead donor rule. So what is the dead donor rule? This is an ethics concept that requires patients to be declared dead before any removal of any organs for transplantation is done. It's unethical to remove an organ from a patient that will kill the patient and transplant this organ to another patient to save another life. Of course, you have living donations, but we're not talking about that. We're talking about removing a critical organ. So you cannot remove the heart of somebody to transplant the heart to another one because this first patient will die. So these patients at that time, after talking to the family, meet the dead donor rule, and then after we conclude this, we exclude ourselves, we leave the room, okay, and then the OPO, the Organ Procurement Organization, comes into the room and talks to the family. And then these patients may be donors, registered donors. So when you go and you renew your driver license in every state, they ask you the question, would you like to be a donor or not? And you say yes or no. So some of them are in the registry. We already know their wishes. They are registered donors. But some of them are not. And sometimes you know their wishes, verbal wishes to the family. Sometimes the families have no clue. And they have to think what the patient, the dead patient, would like them to do. Would he like or would she like to be a donor or not? Overall, 75% of families of potential brain dead donors consent for organ donation. So as you can see, and it's very variable, state by state and even city by city and hospital by hospital, you can have 50% consent rate, you can have 75 or 100% consent rate sometimes. So I'm showing you this because it's also very interesting for you to understand that only 2.1% of all hospital deaths occur when brain death is declared. So it is 50 times less common than cardiorespiratory death. The vast, vast, vast majority of patients who die in the hospitals, in the ICUs or on the ward, die because the heart or the breathing stops. So it's a rare situation. Despite the fact that it is only 2.1%, 73% of all deceased organ donors are brain dead. And the rest give organs by donation after circulatory death, DCD. And then you have, in the slide down, the blue actually is living donors. So you have also donors that, in essence, give a kidney. One kidney to their relatives or to even somebody who's unknown, good Samaritans. And, they had the other kidney and they survive, and the recipient actually also survives because they receive the kidney, for example. One important thing for you also to realize is that with one brain-dead patient, you can save 8 patients' lives because you can transplant 2 kidneys, 2 lungs, 1 heart. You can split the liver and give it to 2 people. You can transplant intestine and pancreas. This doesn't happen with living donors because you can transplant maybe 1 organ maximum. So then what is happening? How many people are waiting for organs? A large number of patients are waiting for organs. And as you can see, the biggest waiting list is for kidneys. That's the most common situation and probably the easiest transplantation that you can do. But you have people who are waiting for livers. You have people who are waiting for hearts, lungs, and others. The black is how many people were transplanted. So this is a nice slide that I just went to the government space. And in the United States in 2014, in the waiting list, there were 124,000 people who were waiting for an organ transplant. And only 29,000 of them eventually received an organ. So 1 out of 4. And then in 2021, as you can see, the 2 lines have converged a little bit, and it's better. Out of 100,009, 40,000 actually received organs. So almost 40% to 50%. And this is the waiting list, as I showed you, in the United States. And this is the University of Michigan stadium. It's called the Big House. Nelson knows that, and Chetan knows that. It's the biggest stadium in the United States and the 3rd biggest stadium in the world. And you can fill the stadium with people waiting in the transplant list every single day. People who eventually will die. So thank you very much, muchas gracias, and I'll take any questions.
I think we have time for a couple of questions. Anyone wants to make a question? It's Dr.
Panos, great talk as usual. And can you explain some of the challenges you encountered when you're trying to explain the concept of brain death in countries such as Middle East or even in India, where death by cardiac death is considered normal?
It's a great question, and we deal with that every day. And part of it is obviously the concept. Part of it is education. Part of it is what is in the media. For example, if a celebrity of some kind becomes brain dead, it would be completely different. It would be a lot of buzz in the media about brain death and how you can save lives. It's difficult. The way I do it is I meet with the families. They know me already because I was managing the patient. They have seen me that I've tried everything I could. Try to decrease the swelling of the brain, try to increase the blood pressure sometimes. And I show them the CAT scan. I explain them step by step. This is how the patient arrived to the hospital. This was the injury that he or she had. This is what we tried to do. We failed. And this is what we did. And eventually, we declared the patient brain dead. One very important observation is that if you allow families to be present when you do the brain death exam, and I've done it, and actually we designed a study to do it, randomize them into staying into the room and not staying into the room, that's a very important situation because they're in the background. I teach the residents and I explain step by step what I'm doing. I'm touching the pupil, the corneal reflex. I'm looking at it. I inject cold water in the ear, blah, blah, blah. And then the most important is when you disconnect the patient from the ventilator and you do the apnea test, and then for 10, 15, 20, 30 minutes sometimes, the patient is not taking any breath. So even a lay person would be able to understand that, he's not breathing. And then after that, you answer the questions, and then you leave the room. You dissociate yourself from organ transplantation, although it's in the back of your mind, of course, all the time, but you don't want to be associated with that part. And then the OPO representative comes in and then talks to the family, and then sometimes they consent, sometimes they don't.
Any other question?
By the way, I don't know if Chentan mentioned that, maybe I missed it. We have the World Coma Day next month. So if you are interested, you can go with the QR code or go to the society website and you'll see it, and would love everybody, one of you, to participate. We need more young and non-atherosclerotic minds to start thinking about the future of this. It will be very important. Yes.
Hi, Dr. Panos. My name is Roberto Navas. I'm a fifth-year medical student from the USFQ. Well, I know a lot about transplant surgeries and the requirements that they have, but I think that the population itself doesn't consider the minority of the population that are able to have organ transplants with difficult, how can you say this, pathologies such as HIV. So what would you say, is it relevant for an HIV candidate for transplant, wait for another HIV person, or is it normal to have a healthy person give the organ to an HIV candidate, would you say? So I think my question is, could you break the bounds within just normal transplantation and the HIV or difficult pathologies that are restricted for this type of donations?
So that's a great question first. Second, I'm not a transplant surgeon, and I'm helping, unfortunately, saving lives after this tragedy, because it's always a tragedy. It's an unexpected event. We're talking about a young person who's driving, for example, and had a car accident or motorbike accident, and now he's brain dead. It's a tragic situation. But I'm not so much involved with that. Based on what I know from the OPO is that it's not just the HLA matching that they do, but they consider all these factors. Yeah, I mean, if you're going to transplant an organ from somebody who's brain dead, for example, has HIV, it would be better if you do it in somebody who, but they have their own criteria, and I don't want to give you false information. What you don't do is that if you have somebody who has cancer somewhere, so that excludes them, except for brain cancers. If you have a glioblastoma, for example, that's not an exclusion. But if you have any other type of cancer, lung cancer, breast cancer, etc., then you are not an organ transplant candidate. So they have very specific and rigorous criteria that they use to exclude or to approve transplantation. And in the end of the day, before you open the patient to take the organ out, you never know. Many times you remove organs, kidneys for example, and then something is wrong and the surgeon decides to throw it away or give it for science, to an anatomy lab if they want. So not necessarily all the donors transplant all their organs there. It's up to the surgeons to decide.
Thank you, Dr. Varelas, for
Thank you.
your